There are three main problems in hematology. So it's a problem with red blood cells, white blood cells, and then finally platelets. So this will cover anemias, which we have so many anemias. We have so many clotting problems, which are platelet problems. And then the third are, of course, white blood cell problems. So that will cover leukemias, lymphomas. So there are three main blood cells. We have red, white, and platelets. All of them are produced in the bone marrow. So you can already imagine there will be several issues that can affect functioning of your hematological cells. This is the component of your blood. So when we draw a blood sample, what's really in it? So we have plasma, which is about, it's 55% of your blood, but most of that is water. So plasma itself is mostly water, 91%. What keeps that water in there in the blood is this 7% of protein in there. Also suspended are the cells. So we have 4 to 6 million red blood cells. Then we have 5,000 to 9,000. These are, of course, your normal range for your white blood cells. And then platelets is, some books say 150 to 450. Your textbook says 140 to 340. These are the other substances dissolved in your blood. There are 5 types of white blood cells. So in a regular CBC, you'll only get a total count of WBC. When you want to find out, so let's say you have an increase in white blood cell count, what does that tell you? When your white blood cell...
There's an infection.
Infection.
Okay, that's not entirely true because again, there are 5 types of white blood cells though. Each one has a different function. So when you have an elevated white blood cell count, it really depends which white blood cell count is elevated. So if you total these percentages here, this is what we call, have you seen an order on the EHR? When you look up labs, there's a simple CBC, but then there's also a CBC with differential. Have you noticed that?
Yeah.
Okay. The differential gives you a breakdown of the white blood cell counts. So let's say your total white blood cell count is 14,000, or let's make it 20,000. It doesn't automatically mean the patient has a infection, but it really depends, well, what is that 20,000 made of? What is that composed of? So if it's mostly neutrophils, then yes, because neutrophils are, what's the function of your neutrophils?
Phagocytes.
Yeah,
To
what
fight infection.
when are they produced? Because you have inflammatory cytokines which stimulate the immune system. So neutrophils are increased in number when you have what invading your body?
Antigen.
What type of antigens though? What type of foreign bodies? Is it viruses? Is it bacterial? Is it, or maybe it's not an invasion, maybe it's just inflammatory response, because those are still going to stimulate your white blood cell count. So if the neutrophils are elevated, then that means it's bacterial. So the patient has a bacterial infection. If it's mostly lymphocytes, then you're dealing with lymphocytes or monocytes, you're dealing more with viral infection. Eosinophils and basophils, these are more on inflammatory conditions. So let's say you're having an asthma attack or a COPD exacerbation. or a flare-up of your lupus, for instance, or other autoimmune disorders. So again, it's not automatic that when your white blood cell count is elevated, doesn't automatically mean that you have a bacterial infection. It really depends what type of, what is that total blood count made of. Any questions so far?
None.
Okay, let me just see if there's waiting.
Professor, you
Yes,
said which two white blood cells it means you have a viral infection.
Lymphocytes and monocytes.
viral, yeah, it's lymphocytes.
Okay.
Mhm.
And monocytes?
Well, monocytes are a type of lymphocyte. I mean, monos are also viral. You've heard of mononucleosis, right? I mean,
Yeah.
you have mono, yeah, which is a viral infection. So that will also increase your monocyte count.
Okay.
Okay, with me so far?
Yes.
All right. So the disorders are not discussed in chapter 29. They're discussed in chapter 30, I believe. So we're just on the assessment chapter. So here are the explanations. Tells you right here. So leukocytes are generally the white blood cell counts. And then you have here granulocytes, which are your neutrophils. The segmented ones are the mature neutrophils, meaning they're ready for fighting. Bands, however, are immature neutrophils. Usually when your body, or specifically your immune system, is attacked and it's losing the battle, the band neutrophil count starts to increase. So have you heard the term left shift? Have you heard nurses talk about that in clinical? Or your instructors say a left shift? What about bandemia? Have you heard that term?
Nope.
Okay, bandemia or left shift indicates that the patient is losing a bacterial infection, because think of, if you hear the news about the battle against ISIS, for instance, right? Or the Taliban. Do they use grown-up men, adult soldiers for battle? I mean, for us, we have no, we have
Yes,
no
they
choice.
do.
We can't really use,
They use children.
right? I'm sorry?
They use children, right?
Yeah. So this is
So
the
I thought you
same.
was talking
So
about the
in
Taliban. I thought you were talking
battle
about
here,
us.
when we're losing, when your body is losing, it will send out children. It will send out band neutrophils, which are your um,
Band cells.
yeah. So the bands are your immature neutrophils. Okay. So the bands here, if they increase in number, this is what we call bandemia, or most old-time nurses, practitioners, doctors will call it a left shift. When you hear that term, it's a bacterial infection. Okay. And you already know why the bands will increase, because again, the body is losing. It will just send out whatever it's got, even the children, even the band neutrophils, which are not ready, they're immature, but we got nothing else, so they will release them into the bloodstream just to fight off. But of course, they're no good, because they're babies. They're not going to be able to perform proper phagocytic functions. And here you have explanations, EOs, what they're used for. Right here, high levels occur in some cancers, lymphoma, parasitic infections, right? So it's not really true that when you have an elevated white count, it's automatically an infection. It really depends what type of white blood cells are are the total white blood cells mostly made of? Questions about that part? You guys still with me?
Yes, Professor.
Okay.
Yes, we're with you.
Yeah, we still here.
Yeah,
I'm
so
here.
the rest, the lymphocytes, the monocytes, what are they for? Okay. Let's go with, okay, this is the life cycle of your red blood cells. It's not really testable, but kind of tells you what the spleen's function is. So as the red blood cells outlive their lives, they die after approximately 120 days, they are recycled. So your macrophages eat the dead red blood cells, and the iron component there is recycled, and the heme and the globin part is also excreted. That's actually the color responsible for why our stool is brown and our urine is yellow. It's really part of the red blood cell recycling. Okay, so nothing is wasted, everything is used for another reason, for another function, another purpose. Let's go with your clotting, because this will help us understand when we go to chapter 37 about DVTs. So this is your clotting. So how do you form a clot? So there are two pathways, extrinsic and intrinsic pathway. When we say pathway, two ways by which a clot is formed. Now let's use an example. Who has been pricked with something lately? Either to check blood sugar or just a paper cut. Who's had a cut lately? Doesn't have to be the last week, let's say in the past 6 months.
Yeah,
All right, what did you have, Troy?
I had a paper cut.
Okay, so when you sustained the paper cut, did it bleed right away?
No, it didn't. It didn't bleed. It hurt at first.
Okay, but then it started bleeding, right?
Yeah.
Okay. Did it bleed for a long time?
No.
No, because that was the extrinsic pathway. Your body made or formed a temporary clot. The extrinsic pathway only takes a few seconds to form. So this is the tissue damage here. This is one or a few capillaries on your finger that got damaged. Every blood vessel that is injured, whether it's a capillary, an artery, a vein, will produce tissue factor. Tissue factor will now initiate or stimulate clotting. So when exposed layers of the vessel produce tissue factor, any platelet that will come by will be attracted to it. And once a platelet sticks to the injured vessel, another platelet will stick, and another, and another, and another. So think of it as an orgy. So a platelet sticks, another platelet will stick to it. Okay, so it will initiate the formation of a clot. But that clot, though, is very unstable. It's not a fibrin clot. It's just a platelet plug. Think of it as a temporary fix. Okay, it's not going to stop the bleeding permanently. It will only take a few seconds, but it's important so that you don't bleed to death from that paper cut. All the while this is occurring, the intrinsic pathway is also occurring. This one will take a few minutes longer though. This will take several more minutes. So that's why if you remember, Troy, if you were not careful, after it stopped bleeding, did it bleed again after a few minutes if you messed with it?
No.
Okay, but had you messed with it,
If I mess with it, yeah, it'll bleed again.
all right, so that will prove that the platelet plug that stopped the bleeding was only temporary. How long before you started to mess with the paper cut and then it won't bleed no matter what you did to it?
It depends. I would say it depends on how deep that cut was. This cut was really like superficial.
Okay.
And
All right. So
it took, I would say, maybe a few hours.
okay, that's when you because you didn't experiment, right?
I
Had
didn't
you
experiment. Yeah.
messed with it, let's say 5 minutes later, you would discover that even if you pressed on it, it won't bleed anymore because
Mm-hmm.
a more permanent plug, a fibrin clot has actually formed. So this is the pathway. So first, extrinsic, it will form a temporary plug. Okay, so just plug your cut temporarily. It's a very unstable platelet plug. Meanwhile, again, the intrinsic pathway takes longer because it's a series of activation. So it starts with the tissue factor, and then factor 7 will um, activate factor 9, factor 10, no, factor 11, factor 9, and then factor 10. They will both meet. So the extrinsic and the intrinsic pathway both meet at this factor right here, factor 10. I'll explain the significance of factor 10 later when we get to DVTs. Once the factor 10 is activated, it will now catalyze prothrombin. Prothrombin will now be activated, forming thrombin. Okay, so prothrombin is not a clot yet. You need thrombin in order to form fibrinogen and then finally fibrin. Fibrin are these strands right here. You see these strands holding together the platelets and the red blood cells?
Mm-hmm.
This is now a fibrin clot. So you need these strands, which is called fibrin, which is formed from catalyzing thrombin. Okay, so this is now the part where your anticoagulants matter. Let me see if I can demonstrate this. Let's use a video. Can you see this YouTube video?
Yeah.
Okay. So listen to this. I won't play the whole thing. I'll stop it somewhere.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A, in combination with 5A, activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded.
Okay, so that's where your clotting cascades form. So that explains your intrinsic and the extrinsic pathway. Again, I'll explain how the significance of that clot formation is with anticoagulation therapy. So we have various types of anticoagulants which will stop the clotting, which is important. Who, by the way, needs anticoagulation? What types of patients will require anticoagulants, meaning we don't want them forming blood clots?
EVT patients,
Okay,
pregnant.
PE, pulmonary embolism patients. Who else? You just finished acute coronary syndromes, right? So so right after a heart attack, the patient also receives heparin, correct?
Yeah.
We talked about stroke, ischemic stroke. Not yet.
No.
Okay,
We're
not yet.
supposed to talk about that tonight, Professor.
Oh, okay, very
Yeah.
good. Yeah, so these are all the patients that will require anticoagulation, meaning we don't want them to form blood clots, or at least we would like to lessen their ability to form clots. Of course, we also have opposite patients who have bleeding disorders, which you will discuss on chapter 30. Under bleeding disorders, we have immune thrombocytic thrombocytopenic purpura, we have thrombotic thrombocytopenic purpura, we have heparin-induced thrombocytopenia, we have hemophilia. Okay, so those are bleeding disorders. And then we also have clotting disorders wherein we have DVTs, PEs, and as I've said already, MIs and stroke patients also. I don't know if your instructor will test these. These are, I think, just nice to know. I don't think we need to memorize the coagulation factors. Something I didn't mention and not mentioned in the video is after a clot is formed, now what? What will the body do next? A clot is already formed. So what's the next step? So Troy had a paper cut. A few seconds later, it stopped bleeding because there was a temporary platelet plug. And then several minutes later, 5 to 6 minutes later, it stopped bleeding altogether because now he has a fibrin clot holding stabilizing the plug, meaning it won't bleed anymore. So what will the body do next? We have a clot. What will the body do to that clot? What is the next step? We have clot.
The wound will close.
Right, so now the clot will now be dissolved. Okay, so right after the clot is formed, the body now tries to lyse or destroy that clot. Dissolve is the proper term. So that is a natural course of events. So after a clot is formed, the body has to break down that clot. So that is known as fibrinolysis. Okay, so I'll explain later why that is significant when we get to therapy of patients with DVTs, okay, with clotting problems. The spleen, this is a nice to know. This will be significant. So let's say, as stated here, what is the function of your spleen? Thank you for reading, Maria.
Well, Professor, the spleen is the largest. Well, the spleen has 4 major functions: hematopoietic, filtration,
Red blood cell production,
immunologic, and storage.
Okay, so it stores not only red blood cells, but also white blood cells and platelets. So if you have a immune or an autoimmune problem, which again will be discussed in chapter 30, one of the interventions there is to perform a splenectomy. Because if you're having autoimmune disorders wherein you have a faulty body function, which instead of storing your blood cells, your spleen is destroying them, specifically the platelets. So it's better off that we remove the spleen so that it stops destroying your platelets. Of course, that is one option in autoimmune disorders. That would be a last resort because, of course, the spleen also performs other functions besides the one I mentioned. So it'll be kind of a last resort. Okay, next thing I want to discuss is okay, here. This table right here tells you common findings. Common meaning regardless of the cause of the anemia, the thrombocytopenia, or the leukopenia, the patient will present with the same signs and symptoms. So when you're coming in with a patient who has a blood disorder, they will have common manifestations. So for instance, if you have a patient with a lymphoma, they usually have distended abdomen because the lymph nodes become enlarged. And of course, most of your lymph nodes are found in your abdomen, and some are also in the thoracic cavity. So this will explain why your abdomen will be enlarged. The liver will also be enlarged, especially if you have these conditions here. Iron overload from sickle cell anemia and also thalassemia. Thalassemia is a rare Mediterranean disorder. This is present in people of Mediterranean descent, around people living around the Mediterranean Sea, Italians, Spaniards, Greeks. Okay, so everybody living in that area are the people who develop thalassemia. We really don't know why. Um, it seems to affect those people right around that region. And all people with anemia, thrombocytopenia, tend to have enlarged spleen for reasons we already discussed, because the spleen is responsible for recycling all these blood cells. So if we have increased destruction of these cells, for instance, they will all congregate inside the spleen, causing it to enlarge. So I'll let you read the rest. Okay. The rest of these symptoms are related to either blood loss or low hemoglobin count. So for instance, here, why would your skin be pale, or why would your nail beds be pale if you have low hemoglobin or low red blood cell? Because what's responsible for your pink color of your skin?
Oxygen.
Oxygen-rich red blood cells. Okay, very good. And remember, of course, your red blood cells are responsible for oxygen transport, meaning without red blood cells, you have no way to circulate oxygen. These are the locations of your lymph nodes. So those would be, let's say, when we talk about AIDS in another semester, or are you covering HIV this semester?
Not directly.
Okay, so this would be when you hear lymphadenopathy. Lymphadenopathy is enlargement of the lymph nodes. So this would be the areas where you'll find the lumps, okay, in HIV patients. Okay, so questions in general when you're assessing somebody for hematologic disorders, these will be the questions you'll be asking. So it really depends on what is your problem. When their lab work shows up either low red blood cells, low platelets, or low white blood cell counts, these would be the questions that you'll be asking. So for low red blood cells, your questions would of course be, well, um, what would possibly cause low red blood cell count? So there's only three possible causes, meaning either the patient is not making red blood cells, two, if their body is are destroying their red blood cells too fast, or three, they could be losing blood. The blood loss there could be acute or chronic. So these questions are all about investigating what is the possible cause. So for instance, if you're trying to see whether they have a decreased ability to produce red blood cells, what would be some of your questions? Would you ask about diet?
Yep.
Yeah, because what
Iron rich.
are nutrients that you need in order to produce red blood cells?
Iron.
Iron, what else?
Protein.
Besides protein, the specific nutrients, folic acid and
Yeah.
B12, right? So those are three major nutrients you need in order to form red blood cells. Or let's say maybe on interview, you find out, oh, they have a good diet. They have they eat regularly green leafy vegetables. They have enough meat. They have enough protein in the diet. Another possibility is, are they absorbing it? Okay, it's one thing to ingest the nutrients. It's another problem to absorb it. So let's say in iron, what do you need in order to absorb iron? What should be in the diet at the same time?
Vitamin D. Or vitamin C.
Vitamin C, okay? So maybe their diet is, let's say high in iron, but then it's very low in vitamin C. Same thing with calcium. Let's say they have a high calcium intake, but then very low on vitamin D, okay? Or maybe it's physiologically they're unable to absorb it. So let's say patients who've had history of gastric bypass surgery. What is that thing we need again in order to absorb vitamin B12? What is that structure or enzyme produced by the stomach?
What, Professor?
The enzyme by the stomach?
Yeah, these are, have you heard of intrinsic factor?
Oh, okay.
You remember that from A&P?
A little, yeah.
Okay. And other questions are, of course, you're looking at, is the patient losing the blood? Is it acute or chronic blood loss? So this would be signs, obviously, of bleeding. And fatigue, of course, is a general common symptom of anemia. You just don't have any energy because there's no oxygen transport. And then palpitations is a natural response. So your sympathetic nervous system will always kick in if you have low oxygen delivery anywhere in the body. And these are your blood work that you need in order to investigate what the possible causes are, and so on. The labs that your instructor will be using on the exam, I doubt if they'll say the hemoglobin is low or the hematocrit is high. They'll give you numbers. Okay, so on a test question, she'll give you data. For example, Robert's hemoglobin is 9 grams per deciliter, and his hematocrit is 32%. His platelet count is 130,000. What would be appropriate questions to ask Robert? A. What is your usual diet? B. Do you have any black tarry stool? C. What medications do you take? D. Have you seen any lumps in your neck or groin?
That's a select all that apply or just one answer?
Is A, B, C, or D?
Okay. I would go with the black tardy stool.
All right, that would be the appropriate answer because you saw that his platelet count is low, 130,000 only, and his hemoglobin and hematocrit are obviously lower than normal. So you would put 2 and 2 together that his platelet count is low, he may be losing blood somewhere, right? And unless there's some obvious bleeding elsewhere, but if not, then it would be hidden bleeding like through your GI tract. Table 29.8, these are the bleeding times. We'll discuss these in chapter 37, which will be next. Have you memorized this yet? Because part of your questions will be related to blood transfusion because these patients, these next disorders involve anemia, thrombocytopenia, and neutropenia. So this will involve transfusions of blood products. Most common question will be blood transfusion. If you look at your NCLEX blueprint, you wouldn't believe how many times they mention blood transfusion. Actually, it's blood products that they mention. So will you get questions on blood transfusion on the NCLEX?
Yeah.
Definitely. So memorize these. Okay. Who can get what blood? So which is the universal donor again?
Oh,
Oh.
Okay, O. Who's the universal recipient?
AB.
AB. Do you guys understand what the RH significance is?
I guess. Yep.
Okay, so if I am RH negative, what can I safely receive?
RH negative of your same blood type.
RH negative. What if I am RH positive? What can I safely receive? Smiley?
can you repeat the question?
If I am B positive, what blood can I safely
for the very first time, including President Trump's ongoing legal battle to hide his tax returns and other financial records from the public.
So if I have RH positive blood, I can receive either positive or negative. So I can safely receive negative because I have nothing to react to. It's really the RH negative persons that are in danger. Is that clear?
Yeah.
Okay. Something I want to clarify on RH negative. If the test question did not specify whether or not the patient receives the RH positive blood the first time, again, the only problem you'll encounter is if the patient is RH negative. They're really the ones that you worry about. So if a test question says that an RH negative patient receives RH positive blood for the first time, meaning if the test question did not specify that, assume that the patient has already been exposed. Let me explain. If I am RH negative today and I receive an RH positive blood for the first time today, will I have a reaction today? If I receive the transfusion of a RH positive blood today, will I have the reaction with this infusion today?
Yes.
Actually, no,
Yes.
because I have not been exposed yet. Meaning this is the first time I'm receiving it. So do I have an antibody to it yet?
No, not yet.
No.
Not yet. Okay, so I may not have the reaction today. However, the next time I'm receiving RH positive blood, what will happen to me?
That's when you will react because
That's when I could die.
will you die immediately, Professor?
What was that, Maria?
Will you die immediately upon exposure?
Well, there's still a chance you could survive, but most likely your mortality is quite high because you already have antibodies against it. Okay, so the concept of the Rh negative versus Rh positive is it's all about sensitization. If this is the first time I'm receiving it, meaning I haven't been sensitized to it yet, meaning I have not developed any antibodies, so I will not attack it this time because this is the first time. But any subsequent exposures, yes, I will have a reaction. You understand that part?
Mm-hmm.
Yes, I got a question about that.
Right. But again, unless the test question specifies in the scenario that this is the very first time I'm receiving it, assume that the patient has previously been sensitized. Do you understand?
Yes, I understand.
Okay. Again, if unless your instructor states in the test question that the patient has never received it before, if there's no such information, then assume that they have received it before and therefore has antibodies against it. All right?
Mm-hmm.
Okay, very good. And these are, of course, the nutrients. Okay, the rest of the blood studies. Okay. I won't discuss that. That's some of it are nice to know.
Professor, I got a question.
Yes, sir.
All right, so you mentioned if, let's say one of our patients is having a blood transfusion and it's their first time receiving this blood, don't we have to monitor them every 15 or less minutes just to see how their body reacts to the blood?
Yes, that's absolutely correct. We'll discuss blood transfusion procedure another week, probably next week. I don't know when it's scheduled. Let me see your. We have IV next week. Yeah, we have transfusion therapies, which is next week after I cover IV. If we have time, we'll continue straight to blood transfusion responsibilities. All right. Any other question? All right, let's proceed to 37 now. So under clotting problems, this is chapter 37, vascular disorders, particularly under thrombosis. Here, venous thrombosis, page 813. So 813, venous thrombosis. All right. So who are at risk? The most important way to manage this is prevention. DVTs don't kill patients. It's really the consequence or the complication that results, usually the pulmonary embolism. It's a silent killer. The patient can, especially if they're not on telemetry, so you walk into your patient's room, the patient's dead already. Chances are it could be a PE. I'm willing to bet $50 each time you walk into your patient's room and you find them dead. It was a PE that killed them. Venous thrombosis is a very common condition that will develop in patients and will cause these problems. It's of course a hospital-acquired complication. It's not an infection, but it's natural consequence of hospitalization. You have to document, you assess them for a DVT every shift, okay? Over the years, I've learned that if I have a day from hell wherein I don't have that much time to completely document on all my patients, I make sure I document that there was no sign of a DVT before, during, and after my shift. So how do I prove that? Well, I document what are the common signs and symptoms of a DVT. Okay. So there are three conditions here. So there are two types of DVT. It can be superficial or deep. The one we're really concerned about is the deep vein thrombosis, because these are the types that will travel to the pulmonary system. I'm not saying superficial thrombosis are nothing to worry about. They can travel also. They can go from superficial vessels down into deep vessels. So either way, you have to worry about venous thrombosis. The most important way again is to prevent. Who do you screen for the risk of DVTs or VTE?
Patients that's
people-
immobile.
Yeah.
Only those patients, or do you assess everybody?
Assess everybody.
You assess everybody. So each patient must be assessed for the risk of venous thrombosis. Chances are most of them. We call the three factors the Virchow's Triad, this one. And Virchow's Triad is mentioned several times in this chapter. One is right here. Okay, so you have the triad, which are venous stasis, endothelial damage, and hypercoagulability. Under the pathophysiology, it mentions here again venous stasis, endothelial damage, and hypercoagulability. Under interventions, under risk factors, here they are again: endothelial damage, venous stasis, and hypercoagulability. Same thing under prevention. So since these three risk factors are what lead to the formation of a blood clot, then that's what you prevent. So what conditions really lead to venous stasis? So what does venous stasis mean, Sandra? Vein and stasis. We know stasis is something stagnant, and venous meaning in the veins. So what does this mean?
It means that blood is not really flowing at its normal rate through the veins.
All right, so they're stuck somewhere, right? So that's what we
Yes.
call venous stasis. Now, the conditions that could lead to venous stasis are the following. Venous stasis occurs in these people right here. So anybody who has immobility, somebody mentioned immobility earlier. So what with immobility? How does immobility lead to venous stasis?
Full of blood. I'm sorry, hold on.
Blood doesn't move.
Okay, because how come blood doesn't move when you are obese, when you have pregnancy, when you have chronic heart failure, when you have AFib, when you're taking overseas trips that last 13, 16 hours long, you have a long surgical procedures. Let's say you have a 14, 16-hour neurosurgery, or you are paraplegic, or you've had large joint surgeries like hip replacement, knee replacement surgeries, okay? Or you're either paraplegic or quadriplegic. So what if you have these conditions? What makes blood not move? What therefore is the only way blood returns to the heart from the periphery?
Exercise. Movement.
Movement of lower extremities in particular.
Okay, so muscle contraction, right? No problem with arterial. You have the heart doing that. So the heart pumps, no problem. The heart pumping, the pumping action of the heart moves blood toward the body, right? Away from the heart. The problem is now the blood returning to the heart because there's no heart down in your legs, right? Nothing is pumping it back up. So the only way blood returns is for your muscles to contract, to squeeze the veins and return them to the heart. The valves of the veins, of course, here mentioned, the valves are helpful because they prevent blood from going back down, meaning as they're squeezed, they only go one way. So the valves close right behind it, allowing only one direction of venous return. So another problem would be if your valves are incompetent now. So let's say years of smoking, or you have varicose veins already. So those are obviously damaged. So that will cause venous stasis as well. So therefore, all these patients, are their muscles moving or contracting normally?
No, it's not.
No, they are, especially those taking overseas trips. So they're sitting there, so blood tends to pool.
I had a
The
patient last semester that he suffered from a PE because he was coming back from China or something like that, and he ended up passing out in the bathroom at JFK.
Yeah, so that started definitely as a DVT, right? And then we had no,
Yeah.
and then it got dislodged, he got PE, died. Yep. The other triad is the endothelial damage. So this is any direct injury to the vessel. So whenever, remember the clotting cascade you saw earlier? So any vessel that is injured will produce tissue factor, correct? And then the tissue factor will stimulate the clotting cascade. So whenever you have a injured blood vessel, which happens when you have surgery, cardiac catheterization, trauma is surgery. I mean, surgery is considered trauma. You have burns, or if you had a prior VTE or DVT. Others which will cause endothelial damage are chemo, diabetes, sepsis. You'll discuss sepsis separately. This is a special condition which takes up almost an entire chapter to discuss. And then finally, hypercoagulability. Hypercoagulability means you have a higher tendency to clot. And these are the conditions that lead to that. Not only an increased number of cells, such as what happens in polycythemia. This is another hematologic disorder discussed in chapter 30. Dehydration. If you have dehydration, what happens to your blood concentration?
Gets higher.
Yeah, because the cells are stuck together, right? Because you have less blood volume, so they're kind of yeah, no 6 feet social distancing, right? If you're dehydrated, the cells are no choice; they have to be close together because there's not enough fluid volume. Okay. um, protein C, which is actually the proper name is activated protein C. So if this thing here is high in number, this will increase your tendency to clot. This thing will be mentioned under the sepsis chapter. Sepsis is mentioned here because it's not really the early sepsis. It's really the severe sepsis type that will lead to DIC, which is clotting, and then you'll end up bleeding in the end. Again, sepsis is a whole entire chapter. I had no time to discuss that. But sepsis, always think of sepsis and DIC together. Okay, so DIC can result from severe sepsis or septic shock, especially. When you smoke, take OCPs, or do both. Okay, those are, again, very high risk factors. And these are the explanation of why they do that. So any question about the triad, the Virchow's triad? So this could be any patient, right? So let's say, Maria, do you have any of these triad right now?
Not.
No, but when I admit you in the hospital, will you have it?
Probably if I don't ambulate.
Right, because what is the tendency? You're told to, you slap a ID band on, you put
lay in
you in
bed
the
and rest.
room. What will you do? Will you walk around?
No.
No, the tendency is you stay in bed, grab the remote control or grab your phone, start texting or watching shows, right? I mean, that's what I would do if I'm hospitalized. Actually, the few times that I was hospitalized, that's exactly what I did. Yeah, I didn't walk around. Not much anyway. I walked to the bathroom, that's it. So that's why you have to assess each patient. Okay, and always remember that if they didn't have it, they could have it once they get admitted. Okay. So that makes your assessment for the risk factors very, very important. Each hospital, there's really no standard risk assessment tool. Each hospital develops their own assessment tool. But what they do have in common is the points. So they put points for each of these. So this is a typical tool. Instead, imagine putting these bullets here into a table, and they have points for each one. If the patient scores 2 or more, they have a high risk factor for VTE. So let's say the hospital puts 70 years old. So that's 1 point right there. If they have AFib, that's another point. So now you have 2 points with those 2 alone. You see where I'm going? Any question? So these are the checklist. Okay, let's put it in a checklist. So this will be put in a checklist with numbers attached to them. Meaning if they have, let's say they smoke. Okay, where's smoking? Right here, tobacco use. That's 1 point already. Or they use oral contraceptive. Do you use oral pills? No, birth control pills. That's another point. So 2 points right there, they're already at high risk. Do you understand?
Yes.
Okay, so does it take much to score 2 or more?
No.
Not at all. So that would put pretty much each patient at risk. Our interventions though, or rather specifically our prevention interventions, so not everybody will receive anticoagulants. So if they say, especially if they score a 1 only, they may just benefit from stockings instead of drug therapy. Of course, if they score higher, then they have to receive anticoagulants. Okay, it's the best protection. However, if there are contraindications because they're at risk for bleeding, which is your number one concern with the use of anticoagulants, then obviously there's a contraindication, then they'll only be using stockings, the SCDs, and of course, ambulation. We'll get to the intervention shortly. Let's go to signs and symptoms. So how do you know your patient has a DVT? What were you learn? What did you learn in fundamentals? Was this discussed? Like what you assess?
Yeah.
For edema,
Mhm.
for hot sensation.
Okay, so here are your manifestations. Take note that it's unilateral. Okay, it's not bilateral.
It's only on one side, right?
Yeah, usually involves only one leg or one calf. Have patients have them on both legs? Yes, of course, but that's not the trend. Usually it affects one leg. So if you see these symptoms here, that's already likely. So what will be your next action?
You could get the compression stockings.
Yeah, but if let's say you have notified a physician on the answer choice.
Okay, yeah, notify the physician. I'm sorry.
Yeah, I would do that because are we sure that they have a DVT?
No.
No. Okay. So it's here. It clearly says may or may not have it. So is it definitive that they have a DVT when you see these symptoms?
No.
No, not yet.
It's likely.
Right. So next action would be to obtain a order because the only diagnostic study is what? So the only way that will, the only test that will diagnose it is a ultrasound right here. Table 37.9. We have possible, we can do blood studies, but the only thing that will reconfirm is visual. Okay, you know how movies, pilots say, do you have a visual? So this is it. Do you have a visual on the DVT? So you have to really find it in order to make a diagnosis. If it's just the leg swelling, the unilateral edema, that's just probable. Okay, so maybe, yeah, it could be a DVT, but in order to diagnose it, you have to go find it. Okay, so the only way to find it is to do a ultrasound. So they'll do a duplex ultrasound on the affected leg. If the patient has symptoms of a PE now, then we will go with a CAT scan. Same thing also, we have to go find it. Where in the lung is the clot? Has the clot traveled now? Okay. If the patient is now showing symptoms of a PE. PE is in another chapter. So these are your interventions right here. So early interventions are, of course, leg exercises. We want the patient to ambulate, okay? And if not, then the patient will be receiving anticoagulants. Have you seen these things? TED hoses?
Which one, Professor?
Have you, no, the stockings, they're usually white. Antithrombotic stockings or thromboembolic deterrent stockings. TED hose?
Yeah.
They're usually black, right?
No, I've never seen.
I've seen them before.
Mine is white. I wear them.
Yeah, it'll be nice, if they come in fishnets, different designs. so that they don't look boring. Maybe we'll encourage patients because some patients don't like to wear them. So maybe if they have, you know, like, I don't know, fishnet designs or lace, maybe. But of course, they won't be effective anymore because the only way they work is if they are really going to compress the leg. I don't think lace stockings would do any compression. Others are IPCs. These are also called sequential compression devices. These are the leg wraps that attached to a machine that alternately inflate and deflate with air. You know what I'm talking about, right?
Yeah, I've seen those.
Yeah, we see these usually for especially post-op patients. They have to wear them. Actually, we put them on all patients, regardless if they're surgical or not.
Don't a lot of athletes use them too?
I'm sorry?
Don't a lot of athletes use it too? Also,
Athletes,
yeah,
you mean the IPC or the compression stockings?
the IPC.
The IPC, I don't think so. Because in the first place, athletes don't have the Virchow Triad. I mean, they're not at risk because they're pretty active, unless they're hospitalized. For high-risk patients, now we administer anticoagulants. So there are 3 main anticoagulants used for DVT. It's really depending on, are we preventing DVT or are we treating a DVT? Okay, but there are 3 drug classes to be used. Vitamin K inhibitors or antagonists are that's warfarin, that's Coumadin. Thrombin inhibitors, indirect thrombin inhibitors are your heparin, as well as your low molecular weight heparin. We have direct thrombin inhibitors are the argatroban and also bilaviridin, which is Angiomax. I'll discuss them shortly and when they are used. But the common ones you see are heparin, right? We either use unfractionated heparin or low molecular weight heparin. Okay. Please take note that what do anticoagulants do? Thank you for reading, Robert.
That's not.
The one I highlighted.
I'll read it, Professor, if he's not there.
Okay, go ahead.
Anticoagulant therapy does not dissolve the clot. Clot
Is that clear?
lysis. That's it?
Yeah, that's it. So anticoagulants do not dissolve the clot. What dissolves the clot?
Body lysis.
The body dissolves
The body.
clot. Right. We do have thrombolytics, but thrombolytics are reserved for acute episodes. So let's say you're having a ischemic stroke, for instance, or you have a massive pulmonary embolus. Those are the only times we use thrombolytics, meaning we do have drugs. The drug is called alteplase, which will dissolve the clot fast in a matter of minutes. But for DVT prevention and treatment, we only use anticoagulants. So back to the cascade right here. We'll replay this thing right about here, and we'll look at the action of the drugs, which is in this table right here, table 37.1. or .10, sorry, and see how they work.
Since the 2 pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade.
Okay, so this thing mentions 10A, and you see where this thing meets the intrinsic and the extrinsic pathway, correct? So your 10A inhibitors are these drugs right here. These are factor 10A inhibitors. So they are your novel anticoagulants, novel meaning new, just like the coronavirus. It's a novel coronavirus. These are novel anticoagulants. These things have no need for monitoring. Right here, it clearly says no routine coagulation test needed. So they're very convenient to use. Patients like it because they don't have to be stuck for blood draws frequently to monitor them, unlike heparin and warfarin. There's also no diet restrictions. See, no instructions here on what diet restrictions to follow. So these are your apixaban or Eliquis. We have fondaparinux, Arixtra, rivaroxaban, or Xarelto. Those are the most common. So these are called 10A inhibitors. So that stops the coagulation right here. So therefore, if 10A is not activated because you're taking apixaban, will you form blood clots?
No.
No. So you stop the clotting cascade right here. So let's continue.
Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst.
Okay, so the next anticoagulant.
Make your clot. This way I got oh shoot, my bad.
What's wrong? Hello?
I'm sorry, Professor. I was talking to myself, but it wasn't on mute. I'm sorry.
Oh, yeah, that's okay. So the thrombin here, which is the next step after 10A activation, is now here. So you have direct thrombin inhibitors and indirect. So let's begin with indirect. So there are two indirect thrombin inhibitors. We have low molecular weight heparins and we have unfractionated heparin. So therefore, if they stop thrombin from being activated, will you form a blood clot?
Not at all.
No, not anymore. So therefore, as early as now, you know about the 10A inhibitors and the indirect thrombin inhibitors. Do either of them dissolve a clot?
No.
No.
What do they do instead?
Stop clotting.
They prevent clots from forming. So if you get a question on a test, do they dissolve a clot?
No.
No.
It's prevent them.
Right. So therefore, what it does is prevent new clots from forming. What will it do to the existing clot?
Leave it alone.
Nothing.
Well, yeah, technically nothing, but will that existing clot grow?
No. Yeah. No. It'll stay the way it is.
All right. Therefore, do they stabilize a clot?
Yes.
Yeah.
Yeah, they will stabilize an existing clot. They do not cause it to grow bigger, giving the body time to do what?
To dissolve it.
The body dissolves it on its own. Are we clear so far? So this would
Yeah.
be used for both prevention and treating an existing blood clot, whether it's a DVT or a PE. The treatment really is the same. Of course, if we're talking about a massive blood clot, a massive PE to be specific, then the doctor will consider a thrombolytic because the patient will die because they will go into shock unless we dissolve that clot. Same thing in ischemic stroke. So a massive ischemic stroke has to be given a thrombolytic because otherwise parts of the brain will die. So those are the only two exceptions. Warfarin. Look at this. This is a vitamin K antagonist. Did you hear vitamin K mentioned anywhere in this video?
Not yet.
No.
Well, we watched it from beginning to the end. Did it mention vitamin K at all?
No.
Absolutely not. What is the purpose of vitamin K, or what is its role in in clot formation?
It aids in blood clotting.
How though?
How?
It increases the clotting factors.
Okay, so Maria mentioned about the clotting factor. Who gets vitamin K? Have you been to a pediatric rotation? Not
Yeah,
yet.
vitamin K goes to newborn.
Yeah.
Right, so why do we give vitamin K to newborn babies?
To help.
Because they can't make it themselves.
Yeah, exactly.
Right, so McCrane is right. The liver, the newborn liver is very immature. It's not capable of producing coagulation factors yet. So to prevent bleeding in a newborn, we give them vitamin K in order for them to be able to for their liver to make coagulation factors. Therefore, they can protect themselves from bleeding. All right, so since vitamin K is never mentioned in the clotting cascade, where does it affect the clotting, therefore? So if you give a vitamin K antagonist, which means it will prevent the liver from synthesizing vitamin K, how does it reduce the likelihood of clotting? Again, vitamin K is used to produce clotting factors. So therefore, if you give them a vitamin K antagonist, will the body have vitamin K synthesis?
No.
No. Without vitamin K, can the body make coagulation factors?
No.
No. However, this will only affect 4 clotting factors because not all clotting factors are vitamin K dependent. So there are only certain factors that are vitamin K dependent. So although it won't totally prevent the body from clotting, but at least it won't also prevent the body from bleeding. I mean, it won't also let the body bleed. Okay. However, since it's a vitamin K inhibitor, so will it affect future or existing clotting factors that are already in the plasma?
Future.
Only future. Okay, so if you notice under the treatment, when we discuss how we give these drugs now, because we have to know, well, how do we administer these? It tells you here under the application, thank you for, because we have to use vitamin K antagonist, which is warfarin, because we can't keep the patient in the hospital forever. They have to be discharged, right? And we can't discharge them on heparin. They have to be discharged on oral anticoagulant, which is now warfarin. Thank you for reading this, Mr. McCrane.
The oral anticoagulant for long-term and extended anticoagulation is warfarin, VKA. Warfarin inhibits activation of the vitamin K dependent coagulation factors 2, 6, 9, and 10.
Okay.
2, 7, sorry. 9 and 10. And the anticoagulation protein C and S. Warfarin begins to take effect in 48 to 72 hours. It then takes several more days to achieve a maximum effect. Thus, an overlap of a parenteral anticoagulant and warfarin typically is required for 5 days.
All right. So does this make sense? So since your warfarin, even if you start it today, when will you see a therapeutic effect?
In 5 days.
up to 5 days. So in the meantime, what will protect the patient from the clot? Will the warfarin do that?
No.
The warfarin is useless during the first few days. It won't provide any protection for the patient. That's why it says here, there is an overlap with a parenteral or an IV anticoagulant. IV or subcutaneous anticoagulant, which is now your. So the doctor can order either unfractionated, which is now your IV heparin, or low molecular weight heparin, which is now your subcutaneous heparin. And you have instructions here for each one. You'll be responsible for reading these because the question on any drug chart or table is what will the instructor always ask you about the drug? Let's say the question goes, a nurse is administering warfarin. What is the question always that follows?
It's like adverse effects.
Either that or your
contraindications,
right? Yeah. What are your responsibilities? What should you do? So here, since you know the antidote for warfarin is vitamin K.
You should administer vitamin K also.
Yeah, so you should have vitamin K ready. Or if it's too high, the other antidote is fresh frozen plasma. Okay, if it's way too high, meaning your vitamin K won't cut it anymore, the patient will have to receive fresh frozen plasma. Because what's in plasma again?
Water.
No, what was in it also besides water and protein?
Red blood cell.
It also contains, no, just the plasma, the clear component. It also has coagulation factors, right? It also has clotting factors in it. Yeah, which makes sense, right? Because vitamin K, warfarin is inhibiting reduction of clotting factors, or your antidote is clotting factors, which is contained in plasma. Low molecular weight heparin, specifically Lovenox, for instance. Here is a, have you ever given Lovenox?
No, Professor.
No.
Have you seen what it looks like?
No.
No.
Yes.
Okay, for McCrane, who says yes, there's an air bubble in the syringe, right?
Yeah.
What do you do with that air bubble?
You flick it out, and then, or you push some of the medication out.
But what does
a
this
little bit.
Look at the highlighted statement I just.
Oh, it says do not expel
you
air
keep
bubble
it in
from
there.
pre-filled.
Yeah, do not touch that air bubble. Okay,
Really?
they put it in there on purpose. Yeah, this is the pre-filled syringe. There is always an air bubble there. Do not get rid of that. Leave it alone. They put it there on purpose. Okay, and where do you give it? Preferably where?
The abdomen fatty tissue.
Above the
iliac crest.
Is this in the middle of the belly?
No.
No, it's in the love handles, right? Okay, so give it close to the love handle, because what's in the love handle that's not in the middle part of the abdomen around the umbilicus? What do you not find there?
Fat.
Fat.
Well, there's plenty of fat there, but what's not found there? In your anatomy,
muscle.
There's no muscle there. Okay, there are no muscles above the iliac crest, right? Yeah, there's not much muscle there. So therefore, what they're trying to say is avoid muscles as much as possible. So this is sub-Q, so do not aspirate, do not inject IM, do not rub the injection site, and rotate sites. All right? Again, in any drug chart, these are the testable part. All right? And this is your antidote, protamine sulfate. You monitor, this is heparin, so you monitor what when giving heparin?
The platelet.
Besides that, to know, yeah, platelet is correct, because you want, this is a side effect. It can cause thrombocytopenia. But as far as your therapeutic, whether or not your therapeutic levels are achieved or not, what blood, what bleeding time do you monitor for any heparin? PTT. Okay, it'll be the same. These are both heparins, whether it's LMWH or UH, they're both heparin, so you monitor the same thing, APTT. However, if you're using low molecular weight heparin, the PTT usually does not need to be monitored. Why? Because the dose actually does not change. If the doctor orders low molecular weight heparin, the dose is fixed. So it's really becoming moot or useless to monitor PTT, because why are you checking PTT? The doctor won't change the dose anyway. Is that clear?
Mm-hmm.
So this is the heparin-induced thrombocytopenia. This is a complication, HIT. Same thing here again. This is another heparin. This also causes HIT, and here is your antidote. And do you know the vitamin K rich foods? Because this is the antidote for warfarin. Because it doesn't make sense if they're taking warfarin, but then they're eating the vitamin K, which is the antidote also. What are those foods high in vitamin K?
Green leafy vegetables.
Okay, so we're talking about kale, broccoli, spinach. Hey, Brussels sprouts, those are very high in vitamin K. It's not like they can't eat them, they just can't eat regular amounts. Okay, they have to control the amounts that they're eating. 10A inhibitors, again, these are novel anticoagulants. So I already mentioned earlier, no routine blood tests. Okay, very convenient, no diet restrictions. This is the antidote, but as you can see, this is an antidote only for which ones? Apixaban and rivaroxaban. Okay. Not all novel anticoagulants have antidotes, sad to say. So you could, although they're very convenient, it's also dangerous because they could bleed to death because there's no known antidote. Angiomax, which is bivalirudin, it's a direct thrombin inhibitor, but it's only used for cardiac catheterization. I have not seen it used in any other purpose, not for DVT, not for PE. It's only used for cardiac catheterization. Argatroban, this is used in patients with HIT, meaning it's still a direct thrombin inhibitor, but it's not heparin. Meaning if your patient develops HIT, but they need anticoagulation, then this is your option. Okay, this is the alternative. So this one still prevents clotting, but without the thrombocytopenia. So again, let's recap. So I have a DVT. You saw my signs and symptoms. Besides the ultrasound, what's another test to maybe, maybe see that I may have a DVT?
Doppler.
Besides the Doppler though. So let's say there's no serious swelling. We just, maybe this, but not really. So what's a cheaper alternative? Because Doppler ultrasound will probably cost $1,000.
The D-dimer is the best one.
Okay. Well, I wouldn't say best one, but this is the
cheaper version.
Cheaper, yeah, cheaper. But again, the D-dimer is another maybe. Okay. What's the only way to confirm whether or not you have a DVT?
The ultrasound.
Only ultrasound. You have to find it. Okay, you have to get a visual. D-dimer is, remember the last step of the coagulation cascade after a clot is formed? What did we say the body does afterwards, after clot is formed?
The body dissolves it.
Right. So the evidence of the clot dissolution is a D-dimer. Thank you for reading. What is this, Kevin?
It
What is-
says, fragment of fibrin formed from fibrin degradation and clot lysis. High results suggest VTE.
All right. So after a clot is formed, when the body starts to dissolve it, the byproduct of fibrin is D-dimer. This is what's left. So after you break up fibrin, which is the clot, it becomes, what's left of it is a D-dimer. This is the normal result. So if it's more than 250 nanograms per ml, that's highly suggestive of a VTE. But can we make a diagnosis based on a D-dimer?
No.
What will
No.
be the next order?
Ultrasound.
The Doppler ultrasound. But at least you're not wasting a Doppler ultrasound, because let's say your D-dimer is low. Do you go proceed with the Doppler ultrasound?
No.
No.
No, what for, right? Why would we order an expensive test when the D-dimer doesn't suggest the presence of a clot or what's left of a clot? Is that clear?
Yes, Professor.
All right. So we diagnosed it, we found it. Now, what is the treatment again? What are the options? What does the patient receive first? Do you start the vitamin K antagonist or the indirect thrombin inhibitor first? What do you give first, warfarin or heparin?
Both together.
But which one first? You have to administer, you can't.
Heparin.
Yeah, heparin first. So you run the IV heparin, and we will practice heparin infusion, calculation, as well as heparin bolus, probably next week. Okay, any question? That's all the time we have. It's exactly 5:40.
No questions, Professor.
Alrighty.
Hey, Professor.
Yes.
They also have like natural blood thinners too, like omega-3 and like ginseng, ginkgo biloba. They have
Correct.
like natural blood thinners as well.
Yeah, so that's
Ginger too,
why
right?
those are avoided if the patient has ordered anticoagulants, because they will now increase the patient's risk for bleeding, right?
Yes, yes.
Yeah, very good. But those are the very good. So that will answer the question on, let's say, what drugs will be avoided. So that's your answer.
Okay.
Yeah, that falls under here. Other drugs, the ones you mentioned, they are herbal supplements that interact with warfarin and other anticoagulants. And it's referring us to a complementary and alternative therapy box, which is right here. Okay, here. So all the things that Smiley mentioned are here under herbal and dietary supplements that may affect clotting.
Green tea.
Any other question? Thank you for that, Mr. Smiley.
No. My question: are you gonna send us this also, the recording?
Yeah, I think
Okay.
I recorded.
Yeah, it says recorded.
Yeah, we did.
Thank you.